Hello, I'm Jim Taylor. I'm president and CEO of Voices of Alzheimer's. We're a relatively young patient advocacy organization for people living with dementia and their care partners, but we are small and mighty. I like to say we're very passionate about finding answers to some of the questions that remain for Alzheimer's disease and related diseases. We've made tremendous progress. The research is now at a very, very exciting point, at least for Alzheimer's, not yet spread as we would like it to the related dementias, but that's coming, we believe, also. So we have a very exciting panel this morning. I'm really delighted with the guests that have agreed to talk with us. You may be aware that last week in San Diego, the annual CTAD International Alzheimer's Research Conference was held, Clinical Trials Alzheimer's Disease, which is a gathering of, I don't know, 4,000 to 5,000 people, researchers and physicians and pharmaceutical companies to talk about and learn and be sure we're not duplicating any effort, but to hear about the exciting progress that's been made in the research. And I'm very delighted that one of the outstanding neurologists that was there last week is our friend Dr. Jeff Burns from Kansas, from the Kansas University, University of Kansas. He's a Jayhawk, unfortunately, but I don't hold that against him. And really wonderful couple, VoA champions, Peter Vandell and Holly Sims, and I'm going to let them introduce themselves. Holly and Peter, want to kick off? Peter, tell us about yourself.
Sure. My name is Peter Vandell. I'm a physician, retired for 5 years. I practiced for 45 years. I trained in both internal medicine and OBGYN. And several years ago, I became more aware of getting older. And one of those was word recognition, and that led to the pursuit of what was going on.
And what was going on?
At that point, I had seen um, three neurologists. Actually, the second neurologist made the diagnosis after an hour exam and a cognitive test. We did a lumbar puncture, and that subsequently came back positive.
And have you been for Alzheimer's? And have you been treated?
I was treated initially with Leqembi um, for, um, I think, for about 12 months.
Yeah.
And then we went on to Kisunla just for out of convenience. And that has subsequently worked. So far, so good.
Holly, thank you.
Oh, my name is Holly. I'm Peter's partner. I've been in healthcare for over 40 years. I'm an APRN. My specialty is anesthesia. I've had some experience working with some neurologists, not a lot, but some. So all of this is very exciting, all the research and the progress and how well Peter has done on the medications. And he didn't mention that after his treatment, his PET scan was negative for amyloid and his blood work for tau was within normal range, which was very exciting after the treatment. And he's doing very well.
Peter, you told me you thought you had plateaued, actually.
Yeah, at this point in time, it was kind of that's why I was interested in seeing what Jeff would free consultation. Um, see what Jeff thinks of where you would go from here. So I'm not doing anything at this point.
We'll get back to that. Jeff, tell us about
Yeah.
yourself, please.
Okay, hi. Yeah, thanks, Jim, for having me, and nice to meet you, Peter and Holly. So yeah,
Thank you.
so I'm
Nice to meet you.
yeah, great. It's great to be here. So I'm a neurologist, and I co-direct as Jim mentioned, the University of Kansas Alzheimer's Disease Research Center. So I'm a I'm a physician and a researcher, and spend my time doing both, and actually trying to integrate the two. How do we make care better faster, more efficient, all that, and get the new diagnostics and the new drugs to everyone who needs them. And so I've done a lot of clinical trials over the years, and now really focused on that kind of work, the biomarkers in practice, and then how do we develop new ways to really scale what we have now, these new tools we have, how do we scale them to everyone who needs them and wants them? So
That, that's why I'm so appreciative of Jeff's work. He's actually trying to take the research we're talking about, and most of us don't understand, and really integrate in that into his practice and make the practice itself as efficient as possible. So, Jeff, I think you're making huge strides. I hear from your contemporaries out there in Kansas. So we're really grateful that you would take the time to join us and give a free consult to Peter while you're here. So
yeah.
let's jump in. We don't ever have enough time, and I'm probably the problem here. But Jeff, we continue to hear positive news coming from the MAB, from the anti-amyloid approved treatments. Can you kind of give us an update of what we heard about the continuing convenience of use and benefit of being on either Leqembi or Kisunla?
Yeah, great. Yeah, no, I mean, I'll start, I guess, by saying Peter's experience, where it sounds like you're responding well you've been on both of the drugs,
Right.
and we're seeing some stability, when, before these drugs, we wouldn't expect that. We're seeing that more and more every day, the longer we're using these drugs, which for me is really encouraging. I sort of have a skeptical, I think everybody in our business is skeptical. We believe the data, we kind of trust it, but we're skeptically watching to see, are we going to get the feedback we want for our patients, that we're seeing some, not improvement, but some stability. And I'm seeing it all the time now in patients. Now, not everybody responds to these drugs, and some people don't at all. But many people do, and it's really encouraging time to have these drugs and be giving them to people and having that impact. So I'll just say that first. And from CTAD, the conference, I thought it was, it's an exciting time for the whole field. We're learning so much, and we're actually now applying things that are impacting patients, and so that's exciting. And what are we learning about these drugs? I guess there's my anecdotal experience that I just laid out, but at the conference there was talk about what happens after 18 months. The study, is there accruing benefits over time from these drugs? The clinical trials just studied 18 months, and we know on average we see about a 30% slowing of decline on average. I mean, some patients are doing better, some aren't responding, and you average that is about 30% slowing. So 5 to 6 months of slowing over 18 months, and that's kind of all we really, really know. But now we're getting more and more data for longer term studies, trying to figure out, does that benefit, improve? Does that accrue? Do we see greater gains over time? And I think the more real world data we get, the more we're seeing that, yes, I think, we can expect continued benefits over the long term, continued slowing over the long term. And I guess another way to think about it is if we treat people, and over 5 years, we only see a 6 month slowing, that's not that big a deal. We see it over 6 months, over 18 months. If we see it over 5 years, not a big deal, but we're seeing, we're probably going to slow things a year to two over those time frames. So accruing benefits is what we're tending to see in the data on both drugs, that we can expect that continued benefit over time. So that's one thing. The other is the real world data. We were worried when we studied them in really highly controlled ways, in the research clinic. And we were worried when we sort of turned it over to the real world that we were going to see higher rates of side effects and, problems delivering the drug. And so far the real world data suggests we're not seeing that. We're not seeing higher rates of side effects, and people are, giving these drugs in a responsible way. So that's very encouraging. And then I guess the third thing to mention is the mode of administration is changing, and for at least Leqembi, where we now have a sub-Q formulation where we can give it, the way GLP-1 drugs are given. You can inject it in the arm once a week. And now that Leqembi is approved for the long-term use after 18 months of treatment with the infusion.
Maintenance.
And so, but the hope is that someday, hopefully relatively soon, we'll have sub-Q injections that we can use from the start.
So
And that'll change the game a lot.
Subcutaneous.
Yeah, subcutaneous. Yep.
Yeah, great. Peter, you're perfect because you've experienced this. And it sounds like very positive experience. What reaction to what Jeff just reported? I mean, it's got to be good news to hear that there was real continuing validation that you may plateau longer and longer.
Oh yeah, I have remained pretty positive at this point that after this when this first came out, and at this point in time, I can see that, with combination of changes that we make in lifestyle, potentially, hopefully, at 77, if I get another 10 years, something else will
Get you first.
cause my demise.
Holly, any reaction or observation, both personal with Peter or from your professional career?
Well, I think it's really exciting to see how well Peter's done. With really no decline, he's done so well with this. I think our question now is, what's next? As far as, to maintain where Peter is, do we start with the sub-Q injections? We're kind of not sure where to go next with that, but we're really excited with everything so far and the results he's gotten.
So you did mention lifestyle, and we know from the Pointer study, which continues to reverberate through the community, that living a healthy life, good Mediterranean diet, being socialized, exercise, are all critical factors to delaying the onset or slowing the progression of the disease. So I know that's probably a recording that Jeff's got in his office that he just hits the button and tells all his patients. I want to move on. There's really terrific news. Jeff, anything else that you want to add? Or the next generation, so we're in the first generation of the mAbs, monoclonal antibodies, and the next generation is pretty exciting. Jeff, want to tell us about trontinemab?
Yeah. That was another, fun thing to see at the conference was more data on the next generation monoclonal antibody against amyloid. So we've got Leqembi and Kisunla now. This would be sort of version 2.0, and with those drugs. And what we saw with that data was they have a technology that allows the antibody to get into the brain more easily. There's a brain shuttle, they call it, that allows that antibody to get into the brain at higher levels. And the early data suggests that it clears amyloid quicker, and most importantly, low rates of side effects, the side effects that we worry about that we call ARIA, the amyloid-related imaging abnormalities, ARIA. So very low rates of that edema or microhemorrhage that we see. We may see it at 20 to 40% in the current drugs, and this data was about 3%. So potentially a game changer. It's a few years out. The phase 3 trials are getting up and going a few years out. But if we didn't have to worry as much as we do about ARIA and getting all the MRIs and safety weren't as big an issue, we would that'd be a game changer. So excited to see how that develops.
Reaction, Holly?
Very excited about that. When I read about that, I thought, wow, it's going to work even quicker. Just a better way to cross the blood-brain barrier. I thought how exciting the results so far are so good.
Peter?
Jeff, the APOE, was that helpful at all with predicting the area in that
in
setting?
the trontinemab? I don't believe so. And there were so few cases. I think there was maybe even only one out of like 80 people.
Wow.
So we're not talking about huge numbers here in terms of tested, but so yeah, not we don't know yet.
Okay.
So, Pete, I was just going to clarify Peter's question to Jeff was about the APOE gene, and if there are a few people who have two bad copies called the E4 gene, about 2% of the population, and we know that in the current drugs, those are small group of individuals who are more likely to develop the ARIA that Jeff mentioned and have the serious side effect. The other small subgroup that is most likely to have ARIA is individuals on coagulants. And these side effects happen usually in the first 6 months and at a time that's very highly monitored with MRIs. So my sense is there is a greater fear than is appropriate about the side effects, the risk of the drugs. My wife was a double four, and she had no side effect and had tremendous benefit of the drug. And I personally feel that that's one of the big inhibitors in moving us into greater treatment, more numbers. So the trontinemab we can educate everybody about the myths of ARIA, but when we get to trontinemab, if it proves successful, it will certainly send a wide message that people are probably going to be more comfortable getting on
Yeah,
medication.
I'll just follow up on that, for two things. First, Peter, I think that's a great question. What you're asking about trontinemab and ApoE, because yeah, that is a good way for us to stratify risk, and maybe the need to do that goes away with trontinemab, hopefully, even doing the ApoE. But yeah, so in terms of risk of ARIA, we do worry a lot about the risk of ARIA because that's important, but really the risk that really need to focus on is the serious side effects, which we see at 1% or less. And ARIA is sort of the canary in the coal mine for most of them. And we detect it before patients know they've got it, and the vast majority. So there's no symptoms with it, and there doesn't appear to be sort of long-term issues or problems that come from somebody having ARIA and not knowing about it and us catching it. We stop the drug temporarily for most people, or we stop it permanently, but for most, we stop it temporarily. The ARIA goes away, we get them back on the drug, and they do fine. So I think ARIA is more a signal, less I mean, we consider it a side effect, but it's more a signal of, okay, let's slow down, let's back off, and let's, avoid serious side effects. If we don't detect it and we continue to treat somebody, then that's where we get into the 1% or less. So I agree. I think we've been very fearful and very vigilant and careful. And the more real world data we get, we mentioned that earlier, that we're getting more and more real world data, and the drug's not, having more side effects than we expect, maybe even having less in some populations like ours in the clinic. And so that really gives us confidence that we know how to manage ARIA, we know how to detect it, and the vast majority of people do well on these drugs.
So, Jeff, what do you mentioned 30% slowing, and that is a continuing benefit of being on the transfusions, being on the MABs. What do we know about the efficacy or the effectiveness of trontinemab?
I think we got a ways to go there. I think it's looking good, but this is where the phase 3 trials, big, longer phase 3 trials are necessary, to get
So,
approval. And but I bet the efficacy I mean, I would expect it to be about the same.
okay,
You
even
know,
if it's no better or
just quicker.
if it's
Yeah,
quicker, yeah, if it's
quicker and
quicker
lower
and
side effects.
primarily just the safety is hugely important to us.
That's the
Yeah.
differentiator right now that I'm seeing.
Yeah. So I'm want to move on. We had a cloud over San Diego, which is rare when we talked about inflammation and anti-inflammation drugs. Do you want to talk about the Evoke trial, Jeff?
Yeah. So there was, huge interest, these GLP-1 drugs, Ozempic and Wegovy, semaglutide, and Novo Nordisk made a big bet, and one I was very happy and proud they did 7, 8 years ago when they started actually two parallel phase 3 trials, and enrolled, I think it was 3,000, maybe 3,300 patients with Alzheimer's to test the GLP-1 drug, semaglutide, or what you hear as Ozempic and Wegovy. Um, And they tested it on people for 2 years and longer, those who stayed in the trial. And so the results were presented there. I actually probably attended CTAD because I knew they were going to present. I've been waiting for these results for a long time. There's a lot of excitement for it. But the results, unfortunately, were negative, meaning we did not see benefit on the outcomes we want to see in Alzheimer's, improve or slow down in Alzheimer's. So CDR sum of boxes and all the cognitive testing and daily activity measures were negative, meaning no benefit. Also meaning no worsening. And some people worry about the weight loss and the muscle loss that we might see with these drugs, but no worsening, but no benefit in terms of those kind of hard outcomes that we want to see move in response to an effective drug. So that was disappointing. And there's a glimmer of hope, I think, in the biomarker data, where we saw some reductions in the p-tau measures. So p-tau 181 and 217, I think another p-tau measure, and then some inflammatory measures were reduced in the blood and the spinal fluid. And so, some mechanistic changes, they were small though, and they clearly didn't translate into cognitive benefits. But so I think we know pretty definitively that at least semaglutide, the GLP-1 drug, does not help people with Alzheimer's. This was a well-done study with patients were really selected appropriately. They were defined with biomarkers and, no benefit in that population.
So, Holly, I know you have thoughts on GLP-1s. Want to share those with us?
Well, I think although the results were negative regarding Alzheimer's, I think as we mentioned before, just talking about overall health. So, a good diet, exercise, sleep, all those things that make a difference in quality of life, your improving lifestyle, I think helps over time. I was disappointed too. I was hoping the results would have been different with that study, but I still think there's hope for it. That gray area, the indirect area that may make whatever, time people have a healthier, better quality of life. And hopefully with the new treatments that are out there, maybe a combination of both, hopefully will improve outcomes.
I agree. I like what you're saying. And I would say if there's a reason for someone to be on them, they should,
Yeah.
that's not brain, but they should be on them. And we still have hope. We're really interested in metabolism at our center, and we think metabolic interventions are going to have an impact. And in this case, we didn't see it. But there's still a reason to think they may be helpful in prevention.
And the safety profiles
are good. Safety profiles are
Yeah.
good, and healthy people probably without amyloid and tau and without memory changes, there may be a role for reducing long-term risk. So maybe even midlife.
don't know
But
that.
we don't know that yet, but there's still hope there.
So,
Can I ask one more question of Jeff?
Peter.
Jeff, I just wanted to ask you, I haven't seen any, but have you seen any studies where diabetics are at increased risk of higher incidence of Alzheimer's in the average population?
Yeah, there's a link between diabetes and Alzheimer's.
There is.
Yep, for sure. And we still don't necessarily know what's driving that link. There's vascular changes in diabetics that can put people at higher risk, but there's also some. Holly, I think you mentioned this when we were chatting before this started, but the idea of type 3 diabetes, where there's insulin and glucose signaling changes in the brain in Alzheimer's disease. And, is that causal? Is that secondary to whatever's happening? We don't really know, but there's a lot of links pointing towards diabetes and, dysregulated insulin and glucose and Alzheimer's. And that's one area that we and many other groups around the country are trying to understand better.
The reason I was so excited about Evoke is because today many, many people who are showing at the PCP visit some cognitive decline then have to wait a year to see a neurologist or a specialist. And we don't want to see Jeff. We want to get started long before we have to see Jeff. And some people are even getting there and then they don't have all the tests they need. So it's an extended period of time. But the PCPs today are comfortable prescribing the GLP-1s because they do it very frequently for diabetes, and for obesity. So for me, this was the golden pill that we could get there easily administered, and we could start it as soon as cognitive issues are appearing. We really got to move part of Jeff's workload to the PCP level. And that's one of the things that Jeff is making so much progress on. How do we optimize? How do we make the most of it? Here's one example of where the patient pathway can be optimized. Do you want to talk about that just a minute, Jeff, or is it too
Yeah.
complex to touch on?
Oh no, I'd love to touch on it. That's what I'm spending my days thinking about and working on is, yeah, how do I mean, the answer to the problem of how do we diagnose earlier and more accurately is not more neurologists. And that's not feasible really, and not a short-term fix either. So it's really how do we get the tools into the primary care practices to help make a diagnosis and detect this. And things like biomarkers are really helping move this forward. We need to surround biomarkers are now available. We need to make them a little more accessible for everybody because they're not that easy to get everywhere. And they're not alone the answer because you have to interpret them in the right context. And when I say that, I mean you need to understand the patient, the right history about the patient, and that's not something that all clinicians are comfortable with because they just haven't done it a whole lot. And so it's like, what questions do you ask and what information do you need to really understand the context and how do you work them up, right? What tests are the right tests next and when? And these are things we can kind of sequence and build in the electronic medical record now. And then, give the script to the primary care and help them interpret it and help them decide what are the next steps. And then we need to support on the back end more with memory clinic and get better at the right patients coming to the right parts of our memory clinic. And I don't think we can think of memory clinic as one door anymore. We need to think of it as doing multiple things. One of them now is using these new drugs to treat, which is one purpose, but the other is support. As people move through, the disease and live with it, we need support from social workers and from behavior experts if there's problems there. Complex diagnosis is another one where we really need a cognitive neurologist. We don't need a cognitive neurologist for everything we do in the memory clinic. So just thinking, how do we break that up and how do we create more doors in so that we can get more efficient about getting the right patients in? And so we've built an ecosystem at our place now within the medical record and with biomarkers and redesigned our memory clinic to really try to do this right, to bring primary care right, to the front line. They're at the front line, but give them the tools they need to really, be effective at the front line in detecting dementia and diagnosing it, and then doing the right things with the patient.
Yeah, thank you for what you do. This is just such music to Holly and Peter and Jim that is wonderful because I have lived with it, and Holly and Peter are living with it today, and it's just really wonderful news. You kind of set up move on to the next topic, which is the blood biomarkers. When you talk about biomarkers, we're really just talking about what we as citizens know as just a blood test, right? So before you tell us about the news that was presented at CTAD, can you tell us where we are with blood biomarkers now? We hear so much they're coming, they're getting better, they'll be here. Are they here and where are they here? And you mentioned the difficulty in some areas in getting access to them. Can you kind of clarify that for us?
Yeah. Yeah, they are. So they are blood tests. And so a simple blood test that's not that expensive anymore. So that's a big deal. What do they do? It's important to think of them. I think it's important to think of them as right now, today, as an amyloid blood test. They tell us the likelihood of whether somebody has amyloid in the brain, and that's where we're using them right now. So they're not really an Alzheimer's blood test. I mean, I think if we think of them as a diagnostic test, where it's a little misaligned with how we use them. They're an amyloid test. So they tell us how likely it is that somebody has amyloid in the brain, which is important if you got memory problems, because that implies this is early Alzheimer's or middle stage or whatever. So important to interpret in context. So they're available. They're a little hard to access because most of them are send outs to some of the labs. And what we turned on in our system, the lab, and it's really hard to do this. You got to get an order built in your medical record. You got to work with your lab to get the processing and all that done, and then the resulting out to the. So it takes a few months. It took us a year. We did it before the FDA approval, so it's a little easier now that we've got FDA approved tests. But those kinds of things have to happen at every health system, or we need to learn and teach our doctors how to send it out to the right labs. And so those are just little areas of friction, and friction adds up. Doesn't take much to really impact how these are deployed. And if you think about a rural clinic or a harder to access clinic, that doesn't have a lot of resources, then it's even harder. Billing and how, does the patient pay for it? All those things add friction, and we're working all that out. We've worked it out within our health system and kind of run an experiment. What happens if we make it available? Do primary care docs use it, or does just the memory clinic use it? And we've found, in 8 months or so, that the memory clinic adopted it immediately for almost every patient. And primary care, because we have an education program and sort of spreading the word about them and trying to teach people how to use them, we've had about 80 primary care docs order the test. So primary care, if they're educated on it and comfortable with it, they will use these tests. They want to use the tests. Their goal is to do the right thing for their patients. So, number one, they want to be empowered to treat their patients. And so we've found it very useful to primary care and then to working with us in the memory clinic more effectively.
Oh, this could be transformational if we can get. Now,
Yeah.
the approval procedures are the same for neurologists as they are for PCPs?
To order it, you mean? Or
I thought for PCPs it was just a rule out.
Oh, well, there's different tests out there. And there's some and based on the characteristics of the test, how sensitive, how specific, there's some that are better to rule out, meaning if you get a positive test, you want to do more testing to confirm it. And you're going to have you're going to have more false positives in a rule out test. You want to cast a wide net and do confirmation. So there's p-tau 181 is a better rule out test. p-tau 217 is a better rule in test. Although I don't know if we're quite there, but we're getting there.
Oh, that's the education process.
Yeah.
PCP. Okay.
Well, we try to keep it. Yeah. So, but at our place, we're just using 217, which we think is very good, both ways, detecting it and even in the right patients, we can consider it confirmatory if it's the right patient and the right level. If it's really high in a patient who has all the characteristics of Alzheimer's, we don't feel we necessarily need to do confirmatory testing.
Confirmatory being PET scan.
Yeah, PET scan or spinal fluid.
Yeah. Peter, Holly, reaction to that?
Well, as you mentioned, the testing, would you use the P217 for someone like me who's asymptomatic at this stage with prior treatment? Would you look at that again in 6 months or 12 months?
Yeah, that's a really good question for tracking sort of response to treatment. We don't have enough evidence there. I would do it. I'd love to do it and be interested in it. In terms of making treatment decisions, I wouldn't use it now. After treatment, there's some reasons to think it may not be a great way to track treatment. So that's where the amyloid PET is better. After somebody's received treatment and we've pulled amyloid out of the brain, amyloid PET will confirm that it's reduced in the brain. But the blood measures, we don't have enough data to say that's a reliable way to track response to therapy. Because one of the reasons is because p-tau 217 reflects, I said it's an amyloid test. It is. It's the best at predicting amyloid, but it also tracks with tau tangles. So if we remove amyloid, but tau goes up, that p-tau 217 value may be going up as well. And so we have to understand that better. But it's not as clean as just amyloid, even though that's how we should think about it when we're using it in practice. It's an amyloid likelihood test. Um, but it also does reflect some tau buildup as well.
So, are you aware of the update about blood tests that was brought to CTAD and kicked by? Just briefly,
Yeah,
what?
yeah, but I mean, what we're finding is kind of what we expect. We test these tests in really well-defined research clinics where we really describe the patients well. Now that we're turning it on in the real world, how are they working? How are they performing? And it's not quite as good. There's a little more noise in the system in the real world um, with these tests. And, it just reminds us, and we need to keep this as clinicians using these tests, that they're not definitive. That's why I've been using the word likelihood. They're likelihood tests. They kind of give us a sense of whether or not amyloid is present and how likely it is. Is it super likely or maybe a little likely? But if we use strict cut points in the real world through this one study that was presented, it didn't perform as well as we expected. Still, I think it's a great test, but we have to be cautious with it and careful and
Right.
keep our eye on these things. Do we
Well,
have the right cut points? Have we defined the
exactly.
right cut points? Yeah.
And the other thing we know is that every year, every 6 months, these tests are improving.
Hmm.
They're continuing to do a great deal, and a number of companies there's a very competitive market for these because it will someday be a great tool in our clinical toolkit. So very, very
Exactly.
positive movement, but we need to remain cautious. Before we go to the next topic, I've been admonished that I forgot two things when we began. I was so excited about our wonderful guests here. One is that the audience can put any questions they have in the chat, and we'll get to the questions, hopefully, if we keep moving. And secondly, this is being recorded so that if you can't catch everything or you don't understand everything that's been said, you want to listen to it again, it will be on our website, and you can also recommend it to your friends. So we've talked about the three, I think, of the three physical characteristics of Alzheimer's as being amyloid, which we talked about, and the third being inflammation, which we talked about with the GLP-1s. The second one is another protein like amyloid called tau, T-A-U, which we believe it's the protein that it clumps together inside the brain and causes what we call tangles. And they are probably believed, if Jeff, if I'm right, to be the more destructive of the elements. So there's been some interesting progress there as well. Jeff, some mixed, two steps forward and one back. But you want to update us on the tau?
Yeah, yeah. So I mean, it's exciting that the field is actively and has been for a while, but they're seeing more and more momentum on this targeting tau, the tau protein. And yes, tau is very tightly linked with the clinical cognitive outcomes. So when tau goes up, memory and thinking go down. That's not the case necessarily with amyloid. We can see amyloid without clinical symptoms, and many, 25% of people over the age of 65 have amyloid and they don't have any memory problems. So, but if you have tau buildup in the wrong spots, you've got memory issues pretty tightly linked. So, we really want to see tau slow, the spread of tau slow. And by removing amyloid, it does appear that we see a little bit of slowing in that tau progression. So that's great. But we really want to stop that tau from moving and spreading through the brain. And so lots of efforts and mainly using these antibody approach, monoclonal antibodies against tau and different aspects of tau. That's ongoing right now. So one study reported out didn't work, big study, a lot of hope in it, but it did not work. But others are coming and rising up and going after different angles of tau. And, we need to keep aggressively pursuing these. Then there's also some new sort of genetic based antisense oligonucleotides, ASOs approaches that are focusing on tau. That's, I think, is exciting. Still early days with tau. and therapies. But we're, seeing phase 2 and phase 3 trials, come about is exciting time for that.
So, Peter, Holly, one of the things I think that's most anticipated or most exciting about the progress in tau is like the HIV community, we want to get to combination therapy. That we know that just removing the amyloids, not, we had hoped, I think, 10 years when Jeff was just starting his practice, that getting rid of amyloid would cure Alzheimer's. That clearly doesn't work. We need additional to attack the additional pathology. Do you have any hesitancies as patient and care partners about combination trials when they come forward and we're looking at different angles? Is that to you, are you as comfortable with that concept as you are with just a single treatment?
You know what, I think that, the people that have been doing the testing have been very successful, and they're putting it out there. I had very little side effects, and I would feel very comfortable in a combination with another agent going forward. I mean, at this point in time, if there is something out there that has little side effects, and even if it's a marginally improvement at this point in time, to me, it's worthwhile.
Holly, any thoughts or concerns about?
Well, I agree with what Peter said. I do have a question. I realize that even if you can decrease the amyloid with these medications that we're using presently, it doesn't mean it decreases tau. But if you can decrease tau, will that indirectly decrease amyloid?
Yeah, that's a good question. We don't, it could, we don't know.
I wasn't
That
sure.
the usual sort of the traditional thinking is amyloid builds up and sort of accelerates the tau
Yeah,
downstream. And so not the other way, but we don't honestly, we don't truly
not
understand it.
sure.
And we actually, our hypothesis at our center is metabolic problems are driving all these things. They're at the root.
Yeah.
Mitochondrial issues are at the root, and these are signals of mitochondrial or metabolic dysfunction. And but we don't know. So I think we need to learn these things, and if we can slow tau, that's how we'll answer these questions. If we slow tau, does it slow cognitive decline? We don't know that yet. Actually, one of the studies showed that tau was reduced in spinal fluid and plasma pretty dramatically from one of these new drugs, but it was only 7 or 8 patients,
Yeah,
Oh, okay.
and we don't know, are we just treating the lab value and
yeah.
it's not translating into benefits for the patient? We don't know that yet. If it is going to translate into benefits for the patient and really slowing in the brain of tau spread. So a long way to go, but exciting. We're on the road
One of
Very
the
to
exciting.
understanding this.
one of the exciting things to me was to learn that ASI, which is the company that manufactures Leqembi, is testing a tau product, and that is a combination trial because
I was
any
just going to ask you that. I heard the same
is on
thing.
Leqembi
Yeah.
and the tau medication, which I can't pronounce. Um,
I can't either.
Okay,
I
thank you. I feel better now. So, I mean, that to me is, we're here. We are
yeah.
doing combination trials, Leqembi and whatever this tau drug is. So it's so exciting to me just to be moving forward. But I got to move forward. And I think the last topic I want to talk about before we start moving toward wrap up is Jeff, this cognito, this possibility of TMS, transcranial magnetic stimulation, has been around for a while. It's used in depression and migraines. Can you tell us about, I mean, the phase 2 results from a small trial were pretty astonishing.
Yeah, I mean, so the idea here is sort of stimulate the brain externally. Can we stimulate the brain with transcranial magnetic stimulation and get it into an oscillation pattern that might be good? And it's a really cool idea. And what the study, at least what I saw, I think what you're referring to is there were some changes in a biomarker after applying this, for this using the Cognito device, which is a visual and auditory stimulation.
You wear it on your head,
Yeah, you wear it.
15 minutes a day for 5 days a week. Yeah.
Yeah. So, and there was a biomarker change. I don't know how many they measured, you know, and there was some EEG patterns that they were looking for where the brain was responding in a way that they wanted to see it. So, kind of on one level, it's kind of okay. We're hitting the brain is responding to this stimulation. Now, again, the question there is, all right, we're seeing kind of a biomarker response, but is that going to translate into better outcomes for the patient and improvements long term? We don't know yet, but interesting sort of idea. And I think back to this idea of combination therapy. I think that's the future here. Is we're going to have drugs that go after various things: amyloid, tau, alpha-synuclein, inflammation, et cetera. We're going to have a cocktail of drugs. We're probably going to have devices like this, technology going at it, and we're going to have lifestyle approaches that we need to continue to push and preach and get people to eat right and exercise and sleep well and reduce stress, all that. So it's really going to be everything combined, really going at this and bending the curve. I think in terms of actually, I think we'll be moving quickly into prevention with all these tools.
Devices are very common in cardiology, right? We have pacemakers, they're critical in the treatment of cardiology. Yet, do you think there will be that the specialist community, neurologists, will have a resistance to non-pharmacological approaches to slowing Alzheimer's?
Oh, I mean, yeah, we got to prove it. There's a lot of marketing out there and various things and overselling and so there's I think a healthy skepticism. But yeah, and we got to prove it, and we got to show the size of the impact and the you know the long-term benefits and all that. So yeah, but that, I mean, it comes down to data and proof and being careful with what we're prescribing and et cetera. So
This device manufacturer is saying that they have a more significant benefit in slowing cognitive decline than the MABs.
yeah,
So it's a pretty big, small trial. So now the results of the phase 3 are going to be critical. Again, Holly, Peter, reaction to the possibility of wearing a device at home that has already been proven safe in treatment of depression and migraines?
I think it's wonderful. I mean, my question is it available now? I mean, is it accessible, and will it do any harm? It sounds like it potentially does a lot of good for a lot of people. So, and is it something that people can easily get if they want to include that in part of their treatment?
I think the phase 3 is underway, and whether they're full or not, I'm not sure, but it would be great. We could easily find out if that's something you want to consider. And I think they'd be extremely interested in after having somebody who's already been on an anti-amyloid. I think the side effects to the current treatments have been very, very small. So I think they have a very good safety profile, unlike, the MAB drugs. Yeah. Peter, sorry.
That's okay. So they're using 40 hertz of power. And when you look at different ways of meditation, there are some apps that you can get that actually use 40 hertz of power. The other question I was going to, and I just started doing it. I only did it a couple of days, but I will let you know how it goes in 2 years. Red light therapy. Do you have any opinion on that, Jeff?
Yeah, this would be another one of those where it's that kind of healthy skepticism.
Yeah.
I think we need to, it's probably not gonna hurt you in any way. If you believe in it and you think it's helping you, I'm not gonna argue with you. But have we proven real benefit and the kind of benefit we like to see before we go sort of policy wide with a drug or an intervention? Not there, just like hundreds of things out there. There's just not enough evidence to say it helps or hurts or either way.
Before we end this, I just want to say, interestingly, I've always had a normal vitamin D level. And shortly before I was diagnosed, my vitamin D level, for no reason at all, fell.
Hmm.
And I know that Holly's had a anecdotal experience with her mom in vitamin D and B12, and I thought I would just put it out there to mention.
Well, that's really interesting. I mean, vitamin D levels on average are lower in people who are diagnosed with Alzheimer's, and there's no evidence that replacing that vitamin D has a big impact on things. However, this is one of those where the cost is low, and you're not going to hurt yourself, and your
Get a
vitamin D
vitamin.
your D level is going to go up
Yeah.
if you take it and
Right.
spend more time in the sun. But
Okay.
yeah,
Great. Emily, I've not been with these unruly panelists. I've not been able to follow chat. Can you fill us in on any good questions we've had or any good comments?
Yeah, I think you guys have been so thorough in this discussion that we've only gotten a few questions. But that said, as we're wrapping up, if there are any other questions, feel free to put it in the chat or the Q&A function. But one pretty quick one that maybe, Jeff, you could cover. There was a question related to blood tests and specifically how blood tests are impacted by sex and race and gender and other socioeconomic factors.
Hmm.
yeah, good question. And I think I'm kind of in the middle of this topic, but I'm not the expert on it. Here's my read of it, though. It's the test works well to detect amyloid in all populations, and I think it works equally well in all populations. What we've learned is if we look across, say, racial groups, white versus African American versus Latino, if we start with who's diagnosed with Alzheimer's, that African Americans look to have sort of not as elevated. The test doesn't identify amyloid as often in that group. And there may be other things like vascular changes that are driving our diagnosis. And so we may see more mixed pathologies in African Americans. And so there's some discrepancies out there. If you look at the literature, you'll see that it maybe doesn't detect amyloid as often or perform. And some people interpret that as maybe perform as well in African Americans. But I think the more recent data is supporting that when amyloid is there, we can detect it just as well across all these groups. So it's kind of complicated by what perspective you start with. So that probably doesn't help answer the question, but I think it performs well in all groups.
That's great, Jeff. So I just kind of want to summarize. We talked about a lot of different topics, but in my mind, I kind of look at the amyloid reporting. It's continued to improve. The next generation is very exciting and a significant improvement in speed and penetration into the brain and safety, most importantly. In tau, still some steps back, some 2 steps forward, some combination trials early, still not where we need to be on tau to begin to have the robust combination trials that we would love to see. Inflammation, not much progress there, significant negative results from semaglutide, but we'll keep hoping that something emerges there. Blood markers, just continual, every 6 months, a new generation, much more progress, some caution that we interpret them correctly, but a potentially revolutionary change for what can be done at the PCP office and the efficiency that they will add for specialists. Transcranial magnetic stimulation, TMS, who knows? It's one of the ancillary things we're looking at, but who knows what'll be there next time. Next time we talk about a major breakthrough in this disease, and just so exciting. Then for me to go to one of these conferences, I wish I could tell every individual person living with dementia this. It is so exciting. It is so rewarding to meet people like Jeff who are this is their career, this is their passion. and they don't work 40 hours a week. They work 60 hours a week. And Holly, they're working for you. And Peter, they're working for you. And they're working for me. And they're working for our children, because we know this is a often hereditary disease. So I just can't say enough how important it is that we recognize the work that's being done in our behalves. So I'd like to ask each of you, we're doing pretty well. This is the first time I've done well on time. So I'd like to ask Holly, maybe you can go first, and then Peter, and then Jeff, final comments or things you want to share with our listeners.
I think the most exciting thing, generally speaking, but kind of covers it all, is hope. You know, for the first time, there's hope for people who are diagnosed, and that the ability to diagnose earlier before it's devastating to somebody and their life. You know, I think that's, you know, and I try to share that with as many people that I know, even with my family, because of my family history, there is hope. And I think if you have nothing else, to hold on to that, and knowing that all this research and all these great results are coming out, and there's continued research. So if I were to use one word, I would say hope. And thank you for all the work that you do, Jeff.
Yeah, thank you.
Thank you so
Thank you
much.
very much. I think that, as you pointed out before, it's a matter of having public education. And for each patient has to be an advocate, or if they can't be an advocate for themselves, they have to have someone who can be an advocate for them.
Jeff, any final words?
Yeah, well, thanks for the praise. And I think everybody in my position, we love what we do, and we especially love when it is impacting patients. And, you know, for 18 years of in my career, the first 18 or so, I had the same conversation and the same drugs, you know, that did, you know, were more like a cup of coffee than, you know, what we got now, which is we're going after changes that are directly linked with the disease. So the conversations changed completely, and we got to keep our foot on the gas pedal. We can't take our foot off the gas pedal. We got to double down. So advocate. You know, we have some headwinds now with funding. I think we're going to come through okay. I'm optimistic, but I think we're going to make it through this sort of turbulent time and keep our foot on the gas pedal and keep moving forward. And I guess the last thing I'll say is, yeah, we're working hard, but it's a team effort, and and patients and volunteers are a
Critical. Yeah.
absolutely essential part of the team. And you know, we do it with you and we do it for you. And so you know, keep volunteering and keep advocating. It makes it go. So thank you.
So who could have better guests than this? I just want a theme here is early detection, early diagnosis, early treatment. We have to be thoughtful in the timeliness of this, and it's incumbent on all of us to get the message out there to educate people that timeliness is effective. Request a cognitive evaluation when you go to your GP. On timeliness, I just want to mention to everybody that VOA is supporting a bill that will be introduced in the House probably on the 17th that will provide immediate Medicare benefits for young onset Alzheimer's patients. So if you're younger than 65 today, you have to wait 2.5 years to qualify for Medicare. If this bill gets passed, it will provide immediate benefit and therefore treatment for Alzheimer's patients. So we're very excited about this. It's called the Bridge Act. You'll be given an opportunity to support it, and we hope you will. And we'll introduce it in the Senate, hopefully in January. So we've got it lined up, and we're going to be pushing very hard to get those benefits down to the younger Americans who have Alzheimer's. So I can't thank you enough, guests and panelists. Peter, Holly, Jeff, thank you so much. And
Thank you.
Thank you.
Thank you. Thanks for what
carry
you
on.
do.
Onward.
Thank you.
Thank you.